All right. Thank you everyone for joining Medicine Grand Rounds today. And I will hand it off to one of our chief residents, Nida, who will introduce both our endowed lectureship with Dr. Matterson as well as the speaker.
Everyone, gives me great pleasure to introduce the endowed lecture series. Dr. Barry J. Matterson is a well-published and widely recognized hypertension researcher and the former chair of the VA Cooperative Task Force on Hypertension. He has established an endowed lectureship in perpetuity to bring leading hypertension experts to the medical grand rounds. The purpose of this lecture series is to expose faculty, house staff, and medical students to prominent hypertension authorities and to provide the opportunity to ask relevant questions. It now also gives me great pleasure to introduce Professor Hoorn, who is a world-leading authority on potassium physiology and the role of the distal tubule renal sodium chloride cotransporter in the pathophysiology of sodium sensitivity and hypertension. Among many landmark publications, his pivotal paper published in Nature Medicine redefined the understanding of the role of sodium chloride cotransporter and the pathogenesis of calcineurin-induced hypertension. Dr. Hoorn's body of work is extremely impressive, and he has published over 200 papers and has been cited over 5,000 times. Without further ado, I'll let Dr. Hoorn take it away.
Thank you very much for the kind introduction. And it's a great honor and pleasure to deliver this Matterson Medical Grand Round for you the coming 45 minutes or so. So my name is Ewout Hoorn. I'm from Rotterdam, the Netherlands. I'm a nephrologist, a clinical nephrologist, but indeed with a specific interest in sodium transport and therefore also in hypertension. So I have no disclosures to make. And I wanted to start off with showing you this picture of Rotterdam. So it's the second city of the Netherlands. It was unfortunately heavily bombed during the Second World War. And therefore we are one of the few cities in the Netherlands with a skyline because there's a lot of modern architecture, as you will be able to appreciate, which makes it sometimes a bit like a United States-like city. And one of the icons of the city you see here, which is the Erasmus Bridge, which just celebrated its 25th anniversary. And the name is omnipresent in Rotterdam because our medical center is also named after Erasmus. So it's a relatively new building. So we started using it in 2018, and it now connects several of the buildings that you can see here, where we have the Children's Hospital here. These are the two science towers. So we also have a wet lab that is located in this building over here. And then the big trunk here is where the clinical wards are. And currently I'm speaking to you from this room over here. So you might start wondering who Erasmus was, which is a bit of a historic and philosophical note, I guess. This was Desiderius Erasmus, so he was quite a famous philosopher who was indeed from Rotterdam, although I must admit that he left Rotterdam quite soon and traveled throughout Europe to become an important philosopher and one of the founders of humanism. But in his work, you can also find several links to medicine. And one of the expressions that is attributed to Erasmus is that it is better to prevent than to cure, which also pertains to the presentation I will be giving to you today. Just by way of full disclosure, I wanted to show this previous publication from 1955. That's why I stole the title for this presentation. And it's actually quite an interesting review to read, written by William Schwartz. And some electrolyte aficionados might recognize this name because he was also the one who described the Schwarz-Bartter syndrome for the first time, which is now referred to as the syndrome of inappropriate antidiuretic hormone secretion. But as you can tell, he had interest for multiple electrolytes, including also potassium. And here you also already read on a sort of enigmatic entity in medicine, which is sometimes referred to as caliopenic nephropathy. and especially he mentions in this review patients who already have kidney damage might be more susceptible to potassium deficiency, which will also be covered during my presentation. So that brings me to the three objectives of this presentation. I will cover potassium homeostasis and focus on the role of the kidney. And then I will be moving on a bit more towards public health to analyze the health effects of dietary potassium intake, blood pressure, and kidney function. And finally, I would like to share with you some insights into our current understanding of potassium in chronic kidney disease. And I think this is really shifting a little bit. We have been seeing potassium with a negative connotation, at least in nephrology, but this is currently shifting, and I will share some of these insights with you today. So I thought it would be nice, since most of you are clinically active, to start with a clinical case, which is actually a patient that I'm still seeing in my outpatient clinic. It concerns a 22-year-old female who had a previous history of deafness. And a few years ago, she presented with muscle weakness to the emergency room. And there it was found that she had a quite severely low plasma potassium levels, a level of 2.2 milliequivalents per liter. So this brings us to the general approach to a patient with hypokalemia. And this year, together with two colleagues from the United States, Morgan Grams and Melanie Hoorn, we published an approach to a patient with hypokalemia that I would like to share with you here. We presented this algorithm where we propose as a first step whenever you are confronted with a patient with hypokalemia to, of course, scrutinize readily identifiable causes first. And of course, loop and thiazide diuretic use are common causes of hypokalemia, gastrointestinal losses, some specific causes like certain drugs, cisplatin, amphotericin, or licorice, which we eat a lot in my country, and it can cause hypokalemic hypertension. Although no one outside of the Netherlands seems to like this candy, so I guess you're safe over there. And especially in hospitalized patients, you sometimes also see acute shifts of potassium into cells, for example, due to an insulin effect. So those are, I think, relatively readily identifiable causes. If these are not present, then, and I think also because of the focus of hypertension, it's very important to emphasize the possibility of primary aldosteronism. And those of you who treat patients with hypertension will recognize that this is a very common cause of secondary hypertension if you search for it. It requires some additional diagnostic testing, especially testing the aldosterone to renin ratio after repleting potassium. And this is important because hypokalemia will suppress aldosterone secretion. And you could even see this in patients who are on diuretic therapy, where you might think that the diuretic is causing the hypokalemia. And of course, this can contribute. But sometimes even in patients with diuretic-induced hypokalemia, you can still find primary aldosteronism as an underlying disorder that is important to recognize because of its specific treatment implications. If this is not the case either, then you are entering a more difficult territory because then hypokalemia is often due to urinary potassium loss, and there are multiple causes, some of which are relatively rare. And here we propose to analyze urinary electrolytes as shown here, sodium chloride, potassium, and creatinine. And actually we are proposing in this review to measure the urine potassium creatinine ratio, similar as we do for proteinuria, where we often analyze the urinary protein creatinine ratio. And because we use spot urines most of the times, especially when analyzing patients, for example, as outpatients or in the emergency room, it might be better to use this ratio not only for proteinuria, but also for analyzing the possibility of urinary potassium loss. And several publications now also support this. You will see something else that you might not be familiar with, which is called the urine sodium chloride ratio, which is I think, a very useful tool, especially in patients who are, for example, vomiting and therefore are having hypokalemia. because then they are losing chloride with vomiting, which will reduce urinary chloride excretion. And in those people, you will see a high urine sodium chloride ratio. And this will be different from patients, for example, who use laxatives. These patients often have metabolic acidosis, hyperchloremic acidosis, which increases urinary chloride excretion and will reduce this ratio. In all other causes, so all of the kidney causes of hypokalemia, this ratio will usually be close to 1, which will be the case also if you use diuretics. So then you see the causes here. Diuretic use, of course, was already one of the readily identifiable causes, but sometimes people don't tell you that they use diuretics. And then the remaining category is more rarely tubulopathies. I run a tubulopathy clinic here at Erasmus, so I see those patients, but of course, in general, they are quite rare, and they also include patients with renal tubular acidosis. So we need additional information because I only provided you with the plasma potassium concentration. So I think it's always a good thing to analyze blood pressure, which was not elevated in this young patient. She did have a high plasma renin and high plasma aldosterone. So I think primary aldosteronism is now very unlikely because she's not hypertensive, and she has a high plasma renin level, which you would expect to be suppressed in primary aldosteronism. So indeed, we checked urinary electrolytes, which are shown here, showing relatively high concentrations of sodium and chloride in close to a 1-to-1 ratio, suggesting kidney potassium wasting, a very high urinary potassium concentration. And when expressed as a ratio with creatinine, it was also much elevated because the cutoff we proposed was 22. We think in these patients it's also useful to analyze plasma magnesium, especially when you consider diuretic use or tubulopathies, which was indeed decreased in this patient, 1.2 milliequivalents per liter. And she also had a metabolic alkalosis. And of course, acid-base balance is another important aspect in the differential diagnosis of patients with hypokalemia. So when we come to the algorithm again, I'm afraid we're stuck in this more complex territory here, but we can leave out multiple causes now, and the remaining categories we had was either diuretic use or tubulopathy. We do test our patients for surreptitious diuretic use, which you can do by urinary screening, which came back negative. So we more and more got the idea that this patient might have, for example, an inherited tubulopathy. So in the next few slides, I will be showing some of the kidney transport pathways for sodium and potassium. And I am fully aware that this is complex and has a high risk of people logging out, so to speak. So therefore, I thought it would be illustrative to bring this movie clip that I was allowed to use through one of my colleagues from the Netherlands, Joost Hoorn, a physiology a professor from Nijmegen. So this is illustrating transport in the kidney tubules, where you have at the apical membrane different transporters, which could be co-transporters or exchangers or sometimes channels. And then solutes move through the cell in cellular transport and leave at the basolateral plasma membrane. And here you also see that at the basolateral membrane, you have different receptors, for example, for angiotensin II, that induce an intercellular cascade and then influence transporter activity at the apical, so the urine side in the kidney tubule. And here you also see that you can block this transport, for example, by using thiazide diuretics, and therefore inhibit sodium chloride reabsorption. So when we take a dive into the tubule, for those of you who are familiar with the findings so far, so we have urinary sodium chloride loss, a renal cause of hypokalemia. This might be pointing to the distal tubule or the distal nephron. And indeed, we know that potassium secretion is regulated here. So this can be shown through this cartoon, where on this side you have the urine side or the apical side, and on the other side you have the blood or the basolateral side. And potassium secretion mostly takes place in the connecting tubule and the collecting ducts, where most of the transport processes are energized by a sodium-potassium ATPase pump, as shown here. And then at the urine side, there is collaboration between a sodium channel and a potassium channel called ENaC, the epithelial sodium channel, and ROMK, the main channel responsible for potassium secretion, the renal outer medullary potassium channel. So this is how electrochemically potassium secretion takes place. But there are two factors required for potassium secretion, one of which is the presence of aldosterone, which is the main mineralocorticoid, not only stimulating sodium reabsorption through ENaC, but at the same time also it is a potassium secreting hormone. The second requirement is distal sodium delivery. So there is the reliance on upstream nephron segments to deliver sodium to ENaC in order to be able to secrete potassium. So that also brings us to the immediate segment upstream of the collecting duct, which is the distal convoluted tubule, which is an area of the kidney tubule that we have a specific interest in. And here you will find as the main sodium transporter NCC, which stands for the sodium chloride cotransporter. It's encoded by the gene SLC12A3. And here you might wonder whether there might be problems with this transporter, which could be due to the use of thiazide diuretics, or when it is an inherited tubulopathy, patients will have the Gitelman syndrome. So Gitelman syndrome is sort of the genetic equivalent of chronic thiazide use. We know that NCC interacts with magnesium transport, and this is an important site for magnesium reabsorption, which is facilitated by this TRPM6 magnesium channel, also located in the distal convoluted tubule. So in this patient, when she was in an outpatient setting, we tested her genetically for mutations in SLC12A3 to confirm Gitelman syndrome, but all these mutations returned negative. So that forced us to broaden our search. And since a few years, we know that additional mutations in basolateral potassium channels, which are important for potassium recycling towards the sodium-potassium ATPase pump, can also give rise to a Gitelman-like phenotype. This is actually a broader phenotype because this potassium channel is expressed also in the nervous system and in the inner ear. So these patients also have sensory neural deafness, which, as you might remember, our patient also had. So we felt we were on the right track and also tested her for this gene, but the mutations again were negative. In addition, she did not have any neurological symptoms that you would expect with mutations in KCNJ10, because these patients often have epilepsy and ataxia. So we then pursued whole exome sequencing, and we found a novel mutation in another basolateral potassium channel called KCNJ16, which is sort of an accessory protein for KCNJ10. And together they form heterotetramers and are important also for potassium sensing. And this was the cause of the Gitelman-like phenotype that we found in our patient. So in summary, this patient had symptomatic hypokalemia. That's how she presented, due to renal potassium wasting. In the end, she turned out to have a rare tubulopathy causing primary sodium chloride loss, so a thiazide-like effect. So all of the things I've shown you could also be induced by using thiazide diuretics, a Gitelman-like syndrome, and also deafness, because KCNJ16 is also expressed in the inner ear. So how do you treat these patients? Often they rely on lifelong supplementation of potassium and magnesium supplementation. And we often also give them potassium-sparing diuretics like amiloride and sometimes mineralocorticoid receptor antagonists to reduce the potassium secreting effect of aldosterone. So why did I bring this case? Of course, this is a very rare cause of hypokalemia. But I think this case nicely illustrates the importance of the distal convoluted tubule, that itself does not play an important role in potassium secretion, but does so indirectly by delivering sodium to the potassium secreting segment of the kidney. And apparently it is important in potassium sensing, which is, I think, a novel insight physiologically. So that brings us to the role of the kidney and our prehistoric diet, because previously in Paleolithic times, we were challenging our kidneys, and we did so especially with dietary potassium. And I thought this was an interesting study that looked into what we were eating prehistorically. These are electron microscopy images of food remains that they found in the desert in Israel, some 780,000 years ago. And what you see here are the remains of seeds, fruits, nuts, vegetables, and plants. And these are the more slightly more tasteful real-life examples. And if you translate this into electrolytes, we were challenged by a high potassium, low sodium diet. In fact, our dietary potassium intake could be as high as over 200 millimoles per day. Whereas currently, we completely reversed this picture by eating a low potassium and high sodium diet. And I think emphasis has been on, and for the right reasons, on the high sodium component of our diet, but undeservedly too less, I think, on the low potassium component of our current diet. And we know that this is also a great contributor to salt-sensitive hypertension. I have young children myself, so I do not deny the challenge of feeding children potassium. But I think recommendations should be in order to increase dietary potassium intake. So this brings us to the way we maintain potassium balance, because you could argue, why do we survive a high dietary potassium intake? Because if all the potassium we took in were to remain in the extracellular fluid volume, a high potassium meal would be sufficient to double the amount of potassium in our extracellular fluid volume. And of course, doubling of potassium in that compartment would mean doubling of the plasma potassium concentration, for example, from 4 to 8 or from 5 to 10, which would of course be life-threatening. So there are several homeostatic mechanisms, starting in the gut, where potassium is being absorbed. Then you will see minor rises in the plasma potassium concentration when eating potassium, but these rises are indeed only minor, because the majority of potassium immediately shifts into cells. And this is orchestrated by several homeostatic hormones, for example, insulin, because we often eat potassium with glucose-containing meals, which will increase plasma insulin. And for example, if we exercise, catecholamines will also facilitate this shift of potassium into cells, thereby preventing acute hyperkalemia. There also is an interesting mechanism, and Professors Preston and Matterson contributed to this evidence, that there might also be a direct gut kidney kaliuretic signaling mechanism, which makes sense if you eat potassium, to immediately have a signal for the kidney to start secreting potassium. Because this shift into cells is a temporary solution, but eventually you need to get rid of the potassium. So this makes sense, although these mechanisms are quite complex and we do not fully understand this gut-kidney kaliuretic signaling mechanism. We do know that these minor rises in plasma potassium are also being sensed, most classically by the adrenal gland, which will translate this into the secretion of aldosterone. But as illustrated by the clinical case, we now also know that the kidney by itself also senses potassium through these basolateral potassium channels, in which this mutation, in which this patient had a mutation. And this will lead not only to kaliuresis, but also to natriuresis. And this brings us to the phenomenon of potassium-induced natriuresis. So when you eat potassium, you will increase urinary sodium excretion at the same time. So this is relatively recent insight, that when we eat potassium, that this will regulate the sodium chloride cotransporter NCC to control distal sodium delivery and thereby potassium secretion. So this is also summarized in this cartoon here. So on the one side, when we consume a low potassium diet, as we typically do, this will phosphorylate and activate the sodium chloride cotransporter, and this will induce sodium reabsorption and therefore contribute to salt sensitivity and salt-sensitive hypertension. On the other side, if we eat a high potassium diet, this will dephosphorylate and inactivate the sodium chloride cotransporter, primarily to increase distal sodium delivery to the potassium secreting portion of the kidney. But the side effect is also that you lose more sodium in the urine, which might have a blood pressure lowering effect. So I think one of the key messages of the presentation as a whole is that dietary potassium might be exploited as a natural thiazide diuretic. And actually, again, Drs. Preston and Matterson looked into this using a very elegant human physiology study where they directly compared the effects of potassium chloride with a thiazide diuretic. Because if this would have the same action, this would be comparable. So they did this in 19 individuals with obesity and hypertension that under standardized settings received either 50 milligrams of hydrochlorothiazide or 35 millimoles of potassium chloride. And here you see that both interventions indeed increase urinary sodium excretion. The effect was a bit stronger for the 50 milligrams of hydrochlorothiazide, but at the same time you could say that 35 millimoles of potassium chloride, which is not a huge amount, is already having a 25 milligram hydrochlorothiazide-like effect. The cheliuretic effect was a bit stronger with 35 millimoles of potassium chloride compared to the 50 milligrams of hydrochlorothiazide. So the interventions are not immediately or directly comparable, but you can see that there are similar responses both in sodium and potassium excretion. Another elegant human physiology experiment was performed by a Danish group where they subjected healthy males, 25, to potassium supplementation, a high dose this time of 90 millimoles per day, and they analyzed the effects on the renin-angiotensin system. So they saw a rise in the plasma potassium concentration from 4 to 4.3 millimoles per liter, also accompanied by an increase in urinary potassium excretion, and also a rise in plasma and urine aldosterone, which you would expect based on a rise in plasma potassium concentration. But the interesting part of this study was that they also analyzed the other components of the renin-angiotensin system and found that not only plasma aldosterone, but also renin and angiotensin 2 were increased by increasing dietary potassium intake. And this is interesting because this suggests indeed that there is sodium chloride loss with a secondary response in the renin-angiotensin system, because the rise in plasma potassium would only cause a rise in plasma aldosterone. So this must mean that there is also a natriuretic response to which the renin-angiotensin system responds as a compensatory response to increase renin and angiotensin 2 to compensate for the increased losses in urinary sodium chlorides. So you might wonder, what is the effect on blood pressure? And in this Danish study, this effect was quite modest, probably because they were including healthy subjects. But there have been many studies with potassium chloride in hypertensive individuals. And if you meta-analyze these data, which was done in this publication, you will see that there is quite a strong blood pressure response of approximately 7 millimeters mercury reduction in blood pressure simply by giving more potassium. And more importantly, this was also true for cardiovascular outcomes in terms of stroke. So increased potassium intake, especially in hypertensive individuals, will reduce the risk of stroke by 25%. So we can also take advantage of this physiological effect of potassium by reducing blood pressure and perhaps also cardiovascular outcomes. So this brings us to real intervention studies, and I like to cite this old study because it was also very elegant in setup in the sense that it analyzed the effects in normal rats of 4 different diets, either a high potassium, high sodium diet, high potassium, low sodium diet, and then a low sodium, low potassium diet, or the low sodium, high potassium diet. So the 4 different variations with sodium and potassium. And the only thing the investigators did was analyze longevity. So they analyzed mortality rates based on these 4 different diets. So what they found, probably not surprisingly, was that there was toxicity and higher mortality rates with the high sodium chloride diets. But at the same time, they also observed this protective effect of potassium chloride. They even mentioned this as potassium being a component of the fountain of youth. It's also very interesting to read because they had sufficient space in those days to elaborately report on their participants. This is Wilson, who apparently liked the diet very much because he became rather obese. And they describe him as massively obese, but also manifestly content. And he survived for quite a long time, which is not to say that obesity might not be a problem, but perhaps if you eat sufficient potassium, it becomes less of a problem. And this brings us to the topic of salt substitution, which is, I think, very topical because there's interesting recent literature on this approach, where as a public health maneuver, 25% of the discretionary use of sodium chloride is being replaced by potassium chloride. This is also a smart solution because potassium chloride has a bit different taste, as some people refer to as it is bitter or metallic, but this is less so if you only replace part of the sodium chloride with potassium chloride. And this is also available commercially, as illustrated here. So as mentioned, 2 recent studies analyzed this salt substitution approach, so replacing part of the discretionary use of sodium chloride with potassium chloride in the community in a very elegant setup. This study used a so-called stepped wedge cluster randomized design, where 6 villages in Peru in South America were increasingly introduced with this salt substitution approach. So they included over 2,000 people, which they treated for at least 4 months with this salt substitution approach. And indeed, they found that it lowered blood pressure, and it also reduced the incidence of hypertension by no less than 50%. So a very strong effect on the incidence of hypertension. More recently, just a few weeks ago in the New England Journal of Medicine, another even larger study was published that was performed in China, which had a bit of the same setup, but for a longer period of time. So here, people were treated with salt substitution in, again, this cluster randomized trial design for an average of 4.7 years. And now they analyze not only the effects on blood pressure, but also on cardiovascular events and mortality. So the study was positive, and I think the study has the potential to become a real game changer, at least in terms of public health efforts to reduce cardiovascular risk. Because indeed the primary outcome was stroke, which salt substitution reduced significantly. And the same was true for major cardiovascular events, for death. And this was not taking place at the expense of more hyperkalemia, because especially as nephrologists, we're dealing with hyperkalemia all the time. And of course, this could be a concern when increasing dietary potassium intake, but this was not observed in this study. Of course, patients with chronic kidney disease were excluded from participating in this salt substitution study. So the question still remains, what about salt substitution in patients with chronic kidney disease? And worldwide, approximately 1 in 10 people will have a form of impaired kidney function. So this is a relevant question, I think. And it's also relevant because cardiovascular disease and hypertension are really a burden for our patients. That's where we lose our patients with chronic kidney disease. So this is really the patient group you would like to give this intervention, but could it be done safely? That brings us to the question, to which degree dietary potassium is a determinant of plasma potassium? So we looked into this and we analyzed in almost 4,000 patients with chronic kidney disease between an eGFR of 15 and 45, how much their urinary potassium excretion was. And you see that on average they excreted 50 millimoles of potassium. The World Health Organization recommends an intake of 90 millimoles, and the Institute of Medicine even recommends 120 millimoles of potassium intake per day. And we often use 24-hour urine potassium as a proxy for dietary intake. So here you would say that they are lacking or have a deficiency of 40 milliequivalents of potassium per day. We also looked into the relationship between urinary potassium excretion and serum or plasma potassium concentrations. We did find a statistically significant correlation, but not a clinically very relevant association, because if you would double the amount of potassium in the urine here, this would lead to only a minor rise in the plasma potassium concentration. So this brings us to fairly recent association studies that looked into the relationship between urinary potassium excretion, again as a proxy for dietary intake, and kidney outcomes in our patients with chronic kidney disease. And now approximately 10 of these studies have been published, here summarized in this cartoon. And the majority of studies shown here show that the higher the urinary potassium excretion, the better the kidney outcomes. So not only blood pressure, not only cardiovascular outcomes, but for patients with chronic kidney disease, it apparently also slows down the progression of chronic kidney disease, which again refers to this potassium deficiency threat, this caliopenic nephropathy that Schwartz already mentioned in his review. Not all studies showed the same. So this study showed that it was associated with lower mortality, but not with kidney outcomes. And of course, as you have it with epidemiology, you sometimes have the opposite findings. And one of the United States cohorts with chronic kidney disease patients, the CRIC cohort, found the opposite association. So most of these studies said it's now time for a true intervention study. So the rationale for such an intervention study could be that we currently have this high sodium, low potassium diet, leading to hypertension, cardiovascular morbidity and mortality, but also to progression of chronic kidney disease. The proposed effects of an intervention with potassium supplementation could be that it increases sodium excretion. Through its effect, its thiazide-like effects on the sodium chloride cotransporter. Of course, there are also vascular effects of potassium that we recognize, vasodilation. It even has effects on vascular calcification, which is very important in patients with chronic kidney disease. And finally, there is also some evidence, especially from experimental literature, that potassium by itself could have anti-inflammatory, anti-fibrotic, and also antioxidant properties. So we took up this challenge and we immediately admit that this was a bit of a provocative idea to start supplementing potassium in patients with chronic kidney disease. But we designed a randomized controlled trial, including, again, patients with an kidney function or eGFR between 15 and 45, with hypertension, which all of our patients have, and progressive chronic kidney disease. For safety reasons, we included a 2-week run-in phase with potassium chloride, open label, 40 milliequivalents, so exactly the amount that is required to replete them to the recommended levels of potassium intake. And if they do not develop hyperkalemia, so if it's safe to supplement potassium, then they move on to the randomized phase where we have 3 arms, placebo, potassium chloride, and also potassium citrate. And because of these association studies, we have a kidney endpoint, so a change in kidney function, but we are also monitoring 24-hour blood pressure, albuminuria, and some surrogate cardiovascular outcomes. So the main study is blinded, so we do not have those data yet. We have included now 250 patients. We need to include 400 patients, but I can show you some preliminary data of the open label run-in phase with 40 milliequivalents of potassium chloride, the first 191 patients. So we see a reassuring increase in urinary potassium excretion as expected and as evidence for adherence to the supplementation. We also see a rise in the plasma potassium concentration of approximately 0.4 milliequivalents. Then, of course, important, how many patients developed hyperkalemia? The minority, fortunately, so 11% of patients. For nephrologists, relatively mild hyperkalemia that was readily reversible. We saw a rise in plasma aldosterone, as you would expect, based on the rise in the plasma potassium concentration. But we did not see the rise in plasma renin, suggesting that perhaps in our patients, we do not see this potassium-induced natriuresis phenomenon that the Danish study showed. We also noticed unexpectedly a tendency towards hyperchloremic metabolic acidosis. So apparently, patients with chronic kidney disease are quite sensitive to the chloride component of the supplementation. And unfortunately, but this is only the 2-week study, we did not see an effect on office systolic blood pressure, but of course we are awaiting the longer-term effects of the 2-year intervention, not only on blood pressure, but especially also on kidney function. We do, of course, wonder why we do not see this blood pressure lowering effect that most of the potassium intervention studies did show. And we wondered whether this might be caused by the rise in aldosterone, which we know is a driver of hypertension in patients with chronic kidney disease, or perhaps this development of metabolic acidosis. So indeed, you might have seen that there are also new potassium binders like this one. And some of these studies that use this potassium binder for hyperkalemia, for treating hyperkalemia, also looked into the effects on aldosterone and blood pressure. For example, this study, which was a sub-analysis of one of the large potassium binder trials, where they indeed see a reduction in the plasma potassium levels with the binder, as expected, and also a commensurate decrease in plasma aldosterone. But interestingly, they also see a reduction in systolic blood pressure, possibly suggesting that aldosterone is increasing blood pressure, whereas normally in healthy subjects, you would not expect the rise in plasma aldosterone from increased dietary potassium intake to increase blood pressure, but perhaps this is different in our patients with chronic kidney disease. And finally, the metabolic acidosis. Again, as mentioned, I think our patients are quite sensitive to the chloride component of the supplementation. And this is relatively recent data indeed showing that a rise in the plasma potassium level can directly cause a form of metabolic acidosis that we refer to as renal tubular acidosis. So this is referred to as type 4 renal tubular acidosis. And we now know that this is caused through a direct effect on ammonia genesis. So here you see a very strong correlation between the plasma potassium concentration here on the x-axis and urine ammonia excretion on the y-axis. So the higher the plasma potassium concentration, the lower the ability of the kidney to generate ammonia, which is required to excrete the dietary acid load. So this might explain the tendency towards hyperchloremic metabolic acidosis that we are seeing, at least in this 2-week run-in phase. So in conclusion, I hope to have shared with you some new insights of kidney sensing plasma potassium, thereby reducing sodium reabsorption, increasing sodium delivery and potassium secretion. So new insights into physiology, but with a clinically relevant side effect, if you will, because dietary behaves as a thiazide-like diuretic. And this brings us to salt substitution, which is now emerging as a public health intervention to reduce blood pressure and cardiovascular risk. And even in our patients with chronic kidney disease, at least the association studies are also showing that higher urinary potassium excretion is associated with better outcomes, specifically kidney outcomes. And of course, we are awaiting the intervention data of our clinical trial. And finally, unexpectedly, but importantly, we see an acidifying effect of dietary chloride, which begs the question whether other accompanying anions might be more beneficial in salt substitution, at least for patients with chronic kidney disease, for example, citrate. And therefore, we are very happy that we also have a potassium citrate supplementation arm in the study. And in patients with chronic kidney disease, we also know that alkali therapy is another way to improve kidney outcomes. So I'd like to acknowledge my colleagues in this potassium intervention study, the principal investigators, the PhD students involved, the research nurses, and of course, all of the patients participating in the study, the Dutch Kidney Foundation, which was very brave in financially supporting this provocative, but we think important study. And I would like to thank you for your attention, and I'm happy to take your questions.
Thank you so much. We really appreciate that. Dr. Weiss, our chair, couldn't be here today. So I just want to quickly mention that in the chat, we have the CME and MOC credit link. And I will maybe hand it over to Dr. Matterson for the first question or comment.
Yes, thank you very much, Amber. And thank you, Professor Hoorn, for a really detailed, wonderful lecture that fits exactly the purpose of this endowed lectureship. Excellent information, and the question that it raises, in my mind at least, is where is the World Health Organization, the American Heart Association, kidney groups, others? Everybody has been pushing restriction of sodium, which is a good idea. But to my knowledge, nobody has really emphasized what you've demonstrated so beautifully, and that is the increased dietary intake of potassium, aside from the fact that it tastes awful.
Yeah, thank you for your comments and for your question. No, I think you're making a very good point. The good news is that I think at least in the nephrology world, there is a shift ongoing. Fortunately, we are also looking more and more into dietary approaches to reduce chronic kidney disease, and thereby there's now becoming more emphasis not only on high sodium diet, but also in increasing dietary potassium intake. Of course, the fear for nephrologists specifically is hyperkalemia. Therefore, we believe these data are showing that patients with chronic kidney disease or impaired kidney function apparently tolerate this oral potassium load. Might be important to further develop this strategy.
Any other questions or comments? Dr. Preston, Dr. Gardner, any others?
Yes, Amber, I have a question. Dr. Hoorn, I greatly enjoyed the lecture and appreciate seeing renal physiology in action again. I won't quite admit to my time as a nephrologist, except to say that I heard Dr. Schwartz talk about metabolic alkalosis some very long time ago. In your patient presentation with borderline hypotension, high renin and high aldo, do you believe there was a component of primary sodium wasting driving the hyperaldo and therefore caluresis, which you so eloquently documented and described?
Yes, that's an excellent point. I do believe so. So the urinary sodium and chloride levels were slightly high, and plasma renin was, of course, very high, also suggesting primary sodium chloride loss. And we know that these basolateral potassium channels will also inhibit the sodium chloride cotransporter, stimulating urinary sodium chloride loss. And indeed, hypokalemia is primarily driven by this sodium chloride loss and the secondary aldosteronism, possibly also by the low plasma magnesium, which might further contribute to caluresis. But indeed, I agree that the aldosterone, secondary aldosteronism, is probably one of the more important components of the severe hypokalemia that she suffered, and that we see also as a challenge in these patients. And literally, it's impossible to normalize their plasma potassium levels, but we strive to levels of 3 or higher in these patients with tubulopathies.
Thank you.
This is Rick Preston. Ewout, I will second Barry's comments about this lecture. This exceeded expectations, and thank you for spending time with us. Do you think there's a difference between the way that the potassium is administered, whether it's a supplement like KCO tablets versus as part of a complex meal. The physiology is different. With the tablets, you get a spike, and with the meal, you get the insulin turned on, so you don't have as much of a spike that would cause a big rapid caloresis right away. Do you think there's an outcomes difference with the two?
Yes, I think so. I'm inclined to think so, at least. And we know, for example, with literally increasing dietary potassium intake by eating more fruits and vegetables, that the absorption in the gut also differs than when you give it as potassium chloride. I think potassium chloride is also, in a sense, a bit unnatural, because dietary potassium is usually potassium citrate, for example, or potassium bicarbonate. But indeed, I think there will be differences in the effects of potassium supplementation and giving it with a meal, which is probably more the natural way. And I think when these effects hold, I think it really should be translated into different dietary approaches, and perhaps not giving more potassium chloride, but more healthy food, basically.
Thank you.
Other comments or questions?
Graham McGregor has had some success in reducing the sodium intake in the United Kingdom. A lot of work, a lot of cooperation with the food producers and so forth, but he's done that. On the other hand, in the stroke belt of South Carolina, our colleagues who have worked very, very hard, going to churches, barbershops, public meetings, all kinds of places, to teach people good dietary habits, particularly in regard to potassium, have not fared very well with that. People either can't afford fresh fruits and vegetables, or they just don't like them. And so very little impact has been made, unfortunately.
No, that's an excellent comment. And of course, you are raising a political question, because apparently some countries have more pressure on the food industry to lower sodium chloride, whereas others don't. And if the countries that do, it translates immediately into lower hypertension incidence and lower stroke incidence. So I think really this is an important public health debate that should be held, and that should factor in not only sodium but also potassium, as you suggest. And the fortunate aspect is that when you are consuming a high sodium diet, potassium is even more effective.
Dr. Fornoni?
Yes, Dr. Hoorn, thanks for the wonderful presentation. Alessa Fornoni here. I'm wondering whether the lower incidence of cardiovascular morbidity and mortality in these Middle Eastern countries, in the Mediterranean, Lebanon, and so on, where actually historically sumac has been the spice being utilized as a salt substitute with high content of potassium and very low content of sodium, could actually be studied or could be responsible for the outcome. Just a comment on that.
No, that's
and I
a
have
great
to correct
comment.
you. I'm Italian, and the licorice in Italy you can find even in the pharmacies. The licorice candies.
I see. Yeah, licorice-induced hypoglycemia is an important entity to be aware of. Now, I fully agree with your comment. I think we can learn a lot from other countries and their dietary habits. And indeed, the Mediterranean diet is, of course, well known for positive effects on cardiovascular outcomes, which might also be attributed to other salt substitutes that might be very effective. So that's a good point. Thank you.
Thank you.
Well, thank you again for a wonderful grand rounds. In the chat, again, you can click on the link for CME and MOC. And thank you everyone for coming, and we'll see you next week. Thanks again.
Thank you.
Thank you very much.